All right. Good evening, everybody. For those of you who are here for your first Hot Topics session, welcome. For those of you who have been here before and who understand what we do and what we're trying to produce, it is education within our pain community, primarily within medical students, residents, fellows, young and older attendings as well. I am not Renee Proscora. I'm Syed Wahezi from Montefiore Medical Center in New York. I'm happy to be the host this evening. We will be talking in part about what's on the screen right now, opioid metabolism, but the umbrella topic this evening is going to be opioid tapering, responsible opioid administration, initiation, as well as tapering off. So when to identify patients for opiate prescriptions, how to place them on opioids properly, responsibly, and also how to taper them off properly and responsibly. Dr. Matthew Meroney from University of Florida, Gainesville will be with us this evening, as well as Priya Singla, who is over at University of Virginia. So we have excellent representation this evening. For our learners tonight, just be mindful that most of you will be not on video during the conversation this evening until we get to our Q&A session afterwards. What we're going to try to do, and I'm going to try to moderate, is our first session with regards to opiate metabolism being about 10 minutes or so. And then our sessions on opioid initiation and then opioid tapering would be about 20 or so minutes. That'll leave anywhere between 5 to 15 minutes for Q&A. If we need to go over, we will. We're certainly here for all of you who are with us this evening, okay? During the course of the lecture, the seminar this evening, if you have questions, please put it in the chat. We'll be using your questions during the chat to present afterwards to our educators tonight. All right. So I will get started, and I'll say I probably have the geekiest portion of the session tonight. I will be speaking with regards to opioid metabolism, and I'll be talking about this with the energy of someone who understands that some of the discussion will be on your boards. Also with a clinical twist with regards to some of this information, with regards to setting up some of the information that Dr. Meroney and Dr. Singla will be presenting as well. I think a lot of what we'll be speaking about in the next 10 or so minutes will be germane to your practice as pain physicians, your understanding of how to monitor your patients, and also, how to do well on the exam, or at least parts of the exam that deal with opioids. Okay, so we'll just get started. My slides are not advancing, and I think that's kind of strange. Okay, hold on one second. Okay, here we go. All right. So here's the general outline. I'll be spending some time just on cytochrome P450 system, opioid chemical structures, which I will use for a framework in hopes of helping people understand how some certain enzymes work, and then discuss that with regards to some of the medications that are listed here, and hopefully help people understand how metabolism and cytochromes play a part into understanding drug tests, understanding how the boards are built, and also understanding how to maybe have a more thoughtful approach to opioid prescribing. Okay. So we'll move forward with this. All right. So phases of drug metabolism, when I speak with my residents and with my fellows, I generally start with this because I want people to understand that there are essentially at the minimum two phases of drug metabolism in general. Phase one are just redox reactions. These are oxidation reduction reactions, where basically what's happening is water is being applied across an agent. Generally speaking, in organisms across an activated carbon molecule, right? And we'll talk about that a little bit when we get into opioids. But an activated carbon molecule, one that generally has a relatively positive electro configuration, and oxygen and hydrogen, usually a hydroxyl group, will attach there. It'll change the molecule. When a hydroxyl molecule attaches to a relatively lipophilic molecule, it makes it more hydrophilic. And when something is more hydrophilic in our bodies, it's more amenable to, well, being shunted into fluid reservoirs, eventually finding its way into the kidney/liver, and then other phases of a metabolism, and then excretion occur. All right. So when one ingests or takes in, consumes an agent, what our bodies generally do to that agent is it makes it more hydrophilic, okay, making it match the properties of fluid and plasma a little bit better than what they were when they first were introduced to the organism. And then either just by that primary phase or also by secondary conjugation, those medications or those agents will be washed away. All right. So again, phase one is essentially a simplistic way of making these agents more polarizing them so that they can be excreted. A second phase is a phase that requires more energy. These are ways that the body will take an agent and add either a glucuronide group or a sulfur group or a glutathione group to the molecules. So this requires transferases, things that use big bulky, these are big bulky enzymes that basically bring together two other big bulky enzymes. And once that happens, then that creates more significant polarization, and that more easily allows for excretion of the agent that was taken in. All right, these are modes of conjugation of phase two. The one that's the most important for opioid excretion, metabolism/excretion, is glucuronidation, which I'll show you in momentarily. All right, this says kind of the same thing. Again, phase one versus phase two. Phase one is applying a water molecule or hydroxyl group across a molecule, and phase two is again conjugation, a molecular action that requires energy to apply a large polar group to another group to improve or make excretion more efficient and effective. P450 systems, what are they? The P450 systems are in general the ones that add these hydroxyl groups. They are also large, even though with phase two conjugation, you're adding very large groups. The cytochromes that work primarily on phase one that add water across in this case, the opioid molecules, these are also large. They require less energy than the phase two types. But because of their ubiquitous nature, they work on several different drug types. On your boards, you'll probably be asked about what kind of CYP agents are important for opioid metabolism. And most, not all, but in most cases, it will be the CYP2D6 subtype of the P450 systems. Okay, there's a 3A4 system as well. Those are primarily cytochromes that are involved with SSRI and NSRI and SSRI metabolism in general. Okay, it's an example of P450 redox reactions. Okay, so here are the chemical structures. I will start with heroin. because it's one of the easiest to talk about. On your boards, you may be asked about diacetylmorphine, right? Now, diacetylmorphine is heroin. Why do we call it diacetylmorphine? This three-ring structure is essentially morphine, which you see right here. You have a 3 position and a 6 position, 3 position and a 6 position that you see over here. And these acetyl groups, for those of you who remember way back into medical school, pre-medical school, undergrad, where you learn about acetyl groups, carbonyl groups, and so on and so forth, esters. This is an ester group, a double bond OO, okay, that is a modestly large polar group, and again, a modestly large polar group that creates a more electronegative section here and a relatively less electronegative section here, because these groups pull electrons this way. Why is that important? That's important because molecularly, what it means about this molecule as compared to some of the others that you see is it's very polar. Polar molecules tend to be able to get into the blood system quick, okay? And heroin can get into the blood system very quick, all right? Whether it's used IV, IM, intranasal, because of this particular property, it can get in quick. And then by basic means of metabolism, this section right here can also cross the blood-brain barrier very easily. So this part is the moiety of the molecule that allows it to get into and integrate with plasma into the bloodstream very more easily. And this part is the section or moiety of the molecule that allows it to cross the blood-brain barrier. So you have an agent that gets into the blood fairly quickly, and then an agent that goes also into the blood-brain barrier fairly quickly as well. And then you have euphoria very quickly too. So almost Pavlovian, you have an agent that's ingested, gets to the blood-brain barrier, and you have euphoria very quickly. So then, organically what happens is that the people who use this particular agent get a high very quickly. All right. So that's the telling thing about heroin. These other agents that are similar to heroin are not much different in terms of their behavior, okay? Some integrate into plasma a little bit less quickly than this one does, but for the most part, they are structures that integrate both with plasma modestly easily, but also can cross the blood-brain barrier, hence some of the reasons why we have problems with some of these medications, okay? The 3 and the 6 positions are important because these are the carbon molecules that are relatively charged and where pharma can attach different groups to these molecules to then create a similar molecule, a similar base with modestly different or varying activity, all right? What the body sees is subtype of heroin or a subtype of morphine. And for many of these, not for all of them, the metabolism will be similar, okay? And what kind of metabolism is that? Well, there'll be single phase or the primary phase where water is being attached across those 3 and 6 groups, or glucuronide transferase molecules that work at the phase 2 level. And so when you have agents that where there are the 3 and the 6 GP or glucose, the glucose and phosphate groups that attach here and here, those are the metabolites of morphine, which you'll probably be educated on both for the boards and likely after the boards as well. Many roads, what I'm showing here, lead to morphine. What I want to show is that these agents, okay, when you see pink in the next few slides, when you see pink, think of an active molecule. When you see yellow, think of ones that are agents that create a degree of CNS toxicity. And that's kind of how I've broken it up for simplicity. So this morphine 3-glucuronide is a glucuronide transferase. So if on your boards you're asked about M3G or M6G and what enzyme has acted upon it, if you know that the G means glucuronide, likely a glucuronide transferase acted on this molecule, okay? Understand that these agents are metabolized in the liver to then be excreted, not all, but many, to be excreted from the kidneys as well. So it's important to understand what happens here and then also what happens there. If the kidneys don't work, or if they don't work well, all right, you also need to understand that both the active metabolite and the inactive metabolite, which sometimes can be toxic, are retained. And when this is retained with the active drug, you have more euphoria and better pain relief / more respiratory toxicity. When these non-analgesic metabolites are increased in concentration within the organism, then you'll have the CNS toxicity. All right, and these are just arrows pointing to the same. Again, here I point you to the glucuronide transferases, which you may be asked about. Again, remember, if the renal system is not working properly, both the inactive and inactive metabolites will build, and you'll have an increased euphoria / increased pain response, and also you'll have an increased CNS toxicity as well, right? I won't go through every one of these. Maybe on a different lecture, I may, for those of you who want to know more about this. I think the basics I've gone over. Understand that these opioids can actually be metabolized. There are agents that are metabolized to more quote unquote clean agents or more active agents by the CYP2D6 system. So oxycodone is changed over to oxymorphone. Why is this important? Well, when you're doing urine toxicity and you see someone who tests positive for oxymorphone, but you've only given oxycodone, if their CYP2D6 is acting appropriately, and I say that with a pause because in some people, there are overactive and in some people underactive CYP enzymes, you'll have a different concentration of oxymorphone to oxycodone. Right? Methadone tends to be pretty clean in terms of how it leaves the body. It's one of the few that leaves not only by the renal system, but can also be excreted through bile and the colon as well. Right? Fentanyl is one of the cleanest agents, does not have a metabolite that is active, and the agent itself is primarily excreted through the renal system. All right. Tramadol, I won't get in deeply into. Buprenorphine, I won't as well. These are metabolic pathways of opioids. You may be asked about again CYP action. You may be asked about CYP3A, and I mentioned 3A4 earlier. This is when it's important because the boards may want you to know, what CYPs are working on what opioids. And if you see a UGT, again, that stands for glucuronide. The GT is glucuronyl transferase. So if you see a metabolite of an opioid that has a 3 or a 6 G, that G is glucuronide, and likely, again, it was acted on by a glucuronide transferase in phase 2 conjugation. Right? These enzymes, I want people to understand also that these enzymes, the CYP enzymes, could be activated or inactivated. When they're inactivated, phase 1 metabolism is decreased, increasing the concentration of the agent consumed. If they are overactivated by some of these agents, and there's a list greater than this, then we will have increased processing and possibly an increased either concentration of metabolites, either active or inactive, depending upon what agents were ingested. Okay, so just understand that these enzymes can also make a difference as to how patients feel with the medication that's been given to them. Right? That's my part. I'm going to shoot this over to our colleagues. So we're going to speak first. I think Dr. Priya Singla will be taking over the mic. And Priya, mic is yours. I will go on mute.
Thank you. So hello, everybody. I'm Priyanka Singla. I am at University of Virginia, and I'll be talking about the opioid therapy. I'm on Twitter, so if you feel that any of your question was not answered here, you can reach out to me on Twitter. I don't have any disclosures. The objectives of today's talk are to talk about opioid initiation, the maintenance of the therapy, what challenges we face, and rotation of opioids. Although, recommendation is that chronic opioid therapy should not be the first line treatment, there are about 22% of patients who are on long-term opioids who have chronic pain. This is a data from a 2019 survey that got published in 2021, which shows that the opioid prescription goes up till the age of 45 to 65 years. And then it tapers down more than 65 years of age. And in terms of men and women comparison, women are more likely to be prescribed opioids if they have chronic pain. The chronic pain in this setting is defined as more than 3 months of pain, which does not include acute pain, active cancer treatment, end of life, and palliative care. So CDC paid attention to the opioid epidemic and came out with guidelines, which were last revised in 2016. However, that led to furor. Everybody stopped prescribing opioids. There were patients who were on opioids for a long time, who prescribers suddenly said that I cannot write it because the CDC says that it's not appropriate. So they came out with a revision in 2019, which left the opioid prescription to the discretion of the provider, just to prevent that mass, sudden stoppage of prescription. However, they do state that opioids are not the first line or routine therapy for chronic pain. And this does not include patients who have active cancer treatment, who have palliative care on board, or are candidates for end-of-life therapies. They further state that every attempt should be made to maximize non-pharmacological and non-opioid pharmacological therapy before considering opioids. They emphasize on establishing goals for pain and function before starting the therapy. And when considering opioids, they advise that the risk-benefit ratio should always be weighed. The benefits of starting the opioids should be more than the risks of the therapy, the drugs themselves, and the risks that come with chronic opioid use. There should be an establishment of treatment goals in form of opioid contract, which should be formalized before any opioids are prescribed. Selection of immediate versus long-acting opioids, I'll go over this later. They recommend to start low and go slow. And then they recommend that the reassessment of pain and function, it should be an ongoing process. And the emphasis is on function rather than pain. A VAS score is not a reliable indicator, in their opinion, about how the patient is doing. However, they do emphasize that function, such as if the patient says that if I take oxycodone, I'm able to function better in terms of I can drop my grandson to school or something of that sort. That is more important rather than just a pain number or I feel good and this is the best thing that could have happened to me. They also say that you should evaluate the risk of harm and discontinue the therapy when the physician thinks that it's not appropriate to continue. Before initiating opioids, an opioid contract should be established, and this should include, again, the treatment goals, the patient's responsibility for safe medication use, not to use alcohol or other sedating substances along with the opioids, secure storage and safe disposal. Opioids should be from only one clinician or practice and one pharmacy. Patients should agree to periodic urine drug testing. And the clinician's responsibility should include that they should be available or have a covering physician available to take care of unforeseen problems and to prescribe scheduled refills. This should be renewed yearly. For initiating therapy, emphasis on starting with short-acting opioid. Initiate any opioid trial with less than 2 weeks of short-acting opioids because it's easier to stop if there are adverse effects. You'll know within a few doses if the patient is getting adequate relief. Starting with extended release or long-acting products have been shown to have greater risk of overdose and non-fatal complications. That was reported in one of the studies. And there is no difference in pain or function that was noted between the short and long-acting forms. They say that you may transition to the long-acting opioid if successful trial and appropriate daily dose is determined. When you're reassessing the patient for appropriateness of the opioids, at each visit, they document 5 A's and assess the 5 A's, which include pain relief, activities of daily living, and the impact of opioid therapy on that, any adverse effects that the patient may be experiencing, aberrant drug-seeking behaviors, and what is the patient's affect. In terms of continuing the opioid therapy, CDC also recommends assessing the risk and harms of opioid use and addressing them as appropriate. The risk factors, which are related to the patient as well as the form of therapy, they should be evaluated. The PDMP data should be reviewed at every visit. Urine drug testing should be done periodically. In the state of Virginia, in the first year, we do 3 times in a year, and then thereafter twice a year randomly. Strongly advise against co-prescribing of benzodiazepines. And there should be arrangement of opioid use disorder. If you identify a patient, you should not just stop the opioids. You should prescribe guidance and treatment availability for opioid use disorder if you identify a patient to have one. The risk factors from opioid misuse, this is from the Benza textbook, family and personal history of substance abuse, young age, mood or personality disorder, history of criminal activity, childhood abuse, regular contact with others who misuse substances, risk-taking behavior, use of substances which lead to dependence, and psychosocial stressors. There are certain risk assessment tools which are available. There is a long list of those. The 3 that are, or the 4 that are listed here are the ones that have been validated. The screen and opioid assessment for patients with pain, which has been revised, the SOAP-R, and the current opioid misuse measure, they measure the abuse potential. Along with the pain medication questionnaire, all these 3 were cross-validated in a study by Lawrence et al. The opioid risk tool is a popular tool as it has only 5 items. It is less cumbersome, and it's a quick way of knowing the risk of opioid overdose. The urine drug testing, it is a very important tool in our arsenal, which can keep the patient safe. It helps us to establish prescription compliance if the patient does not have the parent compound or its metabolites. Then, as Dr. Wahezi outlined, they might not be taking opioids. Identify use of other undisclosed substances. There are certain substances that are not identified on the UDT, and you have to order them separately. Like, for example, at University of Virginia, if we want to test somebody on buprenorphine tramadol, we have to order it separately along with the regular screen. So please be familiarized with what your institution's particular urine drug testing kit can or cannot detect on a particular screen. It can uncover diversion. If the patient is negative on 2 screens, it is important to document when the patient says that the patient took the opioid medication, and are the results consistent with that opioid use. When it should be done definitely before initiating the therapy to know if there are any substances which are present. Marijuana has been legalized in some states, but federally it is not legalized as yet, I think. Then stable patients should be screened randomly or at every visit, depending on the state's rules. The drug metabolites, they help us to identify whether the patient is taking opioids or whether there is a diversion risk, or if there is anything that is going on that is use of illicit substances. So this is a table that lists what the substances look like, and this was covered in the previous talk as well. Just for an example, morphine is a metabolite of a number of drugs, but if the patient has codeine present along with morphine, then morphine is a metabolite of codeine. The patient is taking codeine, and it's not per se morphine. The patient could be taking both codeine and morphine, but definitely codeine is something, if you've not prescribed, that helps you decide what the patient is taking and what is not to be expected. On this slide, I would also want to share that there are certain patients who don't metabolize opioids in the way that sometimes the level of the metabolites are way low than the detection threshold for the lab. So in that case, if the patient is testing negative for the metabolites, I do call the lab and ask them to run at sub-threshold testing, because if the level is below the threshold, the lab will rate it as a negative result, but it just may mean that the patient's metabolism is not converting the parent drug to its metabolite efficiently. The concerns with opioid therapy, we all know that opioids are associated with risks, whether they may be short-term or long-term. Constipation and nausea, vomiting are seen very commonly. Sedation and confusion, they're seen with patients with comorbidities and those who are taking concomitant other substances. Respiratory depression, we talked about, especially in context of morphine. Itching and rash are other two things which are not life-threatening, but they can be pretty cumbersome. Long-term side effects include hypogonadism, osteoporosis, immunosuppression, and HPA axis suppression. Opioids can lead to tolerance. They can lead to opioid-induced hyperalgesia. And then there is always a risk of abuse and dependence. So a word about the difference between tolerance and hyperalgesia. Both will present as ineffectiveness of opioid therapy. So as a physician, how can you differentiate? The basic difference in mechanism is that when the patient develops tolerance, and that happens to almost all the patients, they will develop tolerance at some point. The opioid receptors are downregulated. However, the location of the pain will remain constant. There is waning efficacy of opioids over time. When the dose is increased or there is rotation, tolerance improves. However, in terms of hyperalgesia, the receptors are upregulated. There is an increasing distribution of pain. Waning of opioids waning efficacy of opioids over time. But however, increasing the dose will have either no effect or will make it worse. Opioid rotation. We use this tool very effectively to switch from one opioid to another in an effort to improve clinical outcomes, to have that ratio of benefit versus over the harms, more in terms of favorable to benefits. The dose of the new drug should be selected at a starting dose that minimizes the potential side effects while maintains the analgesic efficacy. The indications for opioid rotation is lack of efficacy, the patient develops tolerance, side effects are such that the patient cannot tolerate therapy. Sometimes the insurance doesn't cover a particular form of the drug. So those would be the indications where we would consider opioid rotation. This is just a schematic that gives a suggestion as to how to convert from one opioid to another. So we've identified a patient whom we want to convert, say, from oxycodone to hydromorphone. So the physician converts to an equal analgesic dose of the current opioid. However, literature doesn't recommend starting at the equianalgesic dose. What is recommended is to decrease the dose by a safety factor of 25 to 50% to minimize side effects. And once the patient is stable on that new drug, we can always escalate the therapy. The three exceptions to this rule are initiation of methadone, transdermal fentanyl, and the oral forms of fentanyl. For methadone, because there is a vast variation in the metabolism, the recommendation is to start at 75 to 90% of the equianalgesic dose. For transdermal fentanyl, this conversion has already been taken into account, so you can start at the equianalgesic dose. However, in oral forms of fentanyl, the recommendation is to start at the lowest dose for oral fentanyl, regardless of what the patient is taking via other means. So this is a paper that emphasizes on the best practices for opioid rotation. And like we talked about, the reduction of 25 to 50% of calculated equine analgesic dose for everything, but except for methadone, transdermal fentanyl, and transmucosal fentanyl. These are my references, and we will take questions at the end. I will hand it over to Dr. Meroney.
Thank you, Priya. That was excellent.
Hey guys, can everybody see that okay? I'm assuming so. You can
I can see it, yes.
Okay, great. Okay, my name is Dr. Meroney. I'm one of the assistant professors at University of Florida. So I'm just focusing on the section, which is obviously kind of an important one, I guess. Tapering, you know, the basic thought process of just who to potentially get off or consider getting off, and you know how to kind of initially think about that. Okay. So again, objectives, you know, consideration from who's indicated potentially, thinking about the risks because there are some, considerations for strategies, and other things that people don't really consider. How do you get rid of these things? Where do you get rid of them? Because that's actually kind of an issue. And where is there a lot of information we still need to look into or research about? So I think it's important to consider that, you know, what are opioids? I mean, and depending on the practice you're in, you may see a lot of them, you may see a little of them, or a combination. And I think it's important to think of them as a tool. It's a tool that can work well in the right scenario and for the right patient. And then with some other patients, it might not be the right tool. So if things are not going the way you would like, you know, it's okay to say this is maybe not working. This, you know, this, as far as I can tell, this therapy is currently failing for a variety of reasons, and maybe we should audible and, you know, back off a little bit. But I think it's very important to realize it is a high risk intervention. So when to consider tapering, I think it's obviously the minority of cases where a patient confronts you and says they want to get off of it, but that's obviously great. So considerations are one that may be overlooked, especially when you're first starting, is unsatisfactory pain control. You know, there's a lot of complications from opioid medications. Hyperalgesia is one of them, which, you know, just that in itself may be the reason you're not getting to where you want to be. Polypharmacy, obviously, if the patient's on other medications that make them more dangerous, such as benzodiazepines, that's, you know, that's something you should be aware of. You should be, you know, factoring that into, you know, I guess your future with that patient. Where this really comes into play specifically, which is probably one of the more common scenarios, is you inherit a patient, or you start a opioid on a patient and then you find out that they're already on benzodiazepines, or maybe another provider, you know, maybe the primary care doctor or psychiatrist or whoever is providing benzodiazepines for an anxiety concern. And so, you know, obviously that makes the situation a lot more dangerous. Sometimes it requires communication with the provider, and you're likely going to be in situations where you both think the other person should stop that sedating medication, and you may not come to an agreement of what's the right way to be. So obviously, you know, having good relationships with other providers that you see on a frequent basis can be really important. Sometimes it can be maybe a little more simple if they have, you know, kidney disease, kidney failure. Maybe morphine's just not the best choice anymore because of the metabolites. If they're demented, or, you know, getting more elderly and they're having more issues with dementia, and maybe anger or different things, it may be worth considering. Maybe even more simply, if they're non-compliant and you're worried about where the medication is going, or they're or inappropriate use, that might make it a little more straightforward. And probably the most obvious, the patient overdoses, has a life-threatening event. You know, that should be, you know, one of the first things you're thinking about. maybe in the near future. So I think it's important to, understand that there are guidelines from the CDC recommending, a maximum dose, and that can be part of the reason that you initiate this conversation with the patient. That look, there's evolving literature and data in regards to opioid prescribing, and here are the recommendations. Here's the max dose, and so it's not that you're just making up this number. It's relatively established. Patients that you should be maybe more conservative with, obviously pregnant patients that are very young. I mean, do you want to have this patient on these medications for the rest of their life? I mean, it's a simple concept. I mean, it's easier said than done, but I mean, I think that it should be a motivating factor. I mean, if the patient has some type of pain phenomenon and they're 18, or is the plan going to be for them to be on that for the next 80 years? I mean, hopefully not. And I also think it's important, especially in the right patient, to explain the benefits of coming off opioids, and the basic thought process. I mean, the best evidence for opioid therapy is short bursts. I mean, the newer fellows, newer trainees might not realize this, but when opioids were really kind of pushed, it was based off of some studies of patients receiving opioids in like outpatient surgical settings, and in that setting where they only were on opioids for a short period of time, days or a few weeks, they found that the addictive potential was very low. It was incredibly low, maybe like 1% or so that of the number of patients that actually had issues with addiction. So that was the initial data that was presented to public and to medicine in general, which obviously didn't really add up over the long period of time. I think it's important to kind of think about what motivates people, what doesn't motivate people, and telling somebody that they're risking their life is not a big motivational factor, though it's not zero. I mean, it's relatively established that opioid related mortality goes up with the morphine equivalent. So you can look at the bottom of the slide. If you're over 200 plus morphine equivalents, your odds ratio of dying from that triples, and it goes down at lower amounts. If you have a male patient, sexual dysfunction, telling them that they're going to have hypogonadism, some of them might take that very seriously. Obviously, that can affect women as well. But the chance of falls, fractures, low testosterone, those are real things. Those are going, some of these things like the hypogonadism, the low testosterone, they're going to happen. Telling people that, if they have issues with constipation, nausea, energy level, dysphoria, those very likely will be improved to some degree. It starts to become maybe a little bit more palatable argument. But I think it's incredibly important to have an understanding of the risks associated with opioid tapering. It's beyond just making someone upset or making them, withdraw. I have colleagues that have tapered opioids, and they've had patients commit suicide. And even if it's done relatively, I feel like by the book, the risk is real. A lot of these patients have chronic pain. They're going to have depression. They're going to have anxiety. They're going to not be in a good place. And so it is going to fluster their world to some degree, even if it may put them in a better place. It can be a big deal, and maybe the biggest deal that patient's dealing with in their life at the time. So it's really important to think about if you're going to taper, if you're going to go in that direction, among other things, the speed at which you're going to do that. If the patient's not putting themselves at their life at risk due to abuse, overdose, then we really want to try to avoid abrupt discontinuation, and I'll show you kind of a little bit data beyond that, but it's likely not going to go well, at least from the patient's standpoint. But I think it's obvious that withdrawal symptoms and psychological stress is going to explode. And what's going to happen is if those patients, they may just see it as that, even though you're doing that, for good reasons, they may just say in their head that this is impossible, and they're going to have to find other options to treat this problem. And that's where they're going to go to illicit drug use. And something that's probably overlooked a little bit is, these patients that, if you initially decrease their opioid source, and then they obviously their tolerance drops, and then they over time find illegal ways or other forms of that medication, or even just a refill, then they may take what they think that they can handle, and then they'll overdose and have, a life-threatening event. And it goes without saying that, patients that were already benefiting from the pain relief will have less pain relief. So, these are not easy conversations, but you really do want to give someone a heads up so that they're not surprised about how they feel about the symptoms, anxiety, headaches, at its peak, nausea, muscle aches, insomnia. The first day, they'll notice that within the first day. It's going to peak in a few days. But if the patient's on these medications for a long period of time, those symptoms may last weeks to months. They might have this kind of dysphoria. And so there are some medications that you can consider using. The alpha-2 adrenergic agonists, you can give them some PRN, antiemetics, antidiarrheal agents, muscle relaxants, obviously over-the-counter medications, and touching base with the patient, making sure that they at least have an idea that you're listening to care, and if you have to slow it down, that's something worth considering. So again, there's a lot of data showing that you really want buy-in from the patient, or it's potentially not going to go as well. So really kind of explaining the reasons, trying to, point out the positives, what to expect, talk about they're obviously going to be concerned about pain control. So pointing out, strategies, other medications, other ways of dealing with that. And pointing out that you're going to follow up with them frequently, especially when this is first starting, because that's when they're going to be probably the most anxious, when you're just initiating this taper. So again, it can be life-threatening. Well, from a depression standpoint, it can be life-threatening to discontinue this really quickly. So you really only want to do that if they're putting themselves in a life-threatening situation. So the big questions are going to be: do you fast or slow? And it's really going to be individualized. And if someone's on opioids for over a year, it's likely going to require a slow taper. The CDC does give some basic thought process on this. So a decrease of 10% per month is kind of a good place to consider. And that's if they've been going or had these medications for a long period of time, like over a year, which a lot of patients will. If they've only been on that medication for weeks, then you could likely be a lot more quick. So instead of 10% per month, you're considering weekly titrations, 10% a week. The VA takes maybe a slightly different but similar approach, where it's 20% over about a month, but 5 to 20%. But they may get as aggressive as decreasing the amount every few days. So this is a good example of kind of the maximum and minimums of tapering. I kind of like thinking about things that way. So on the left-hand side, you can see that it goes through month 1 to month 9. And this is this example, the patient's taking 90 milligrams of morphine 3 times a day, so 270 morphine equivalents. And over a 9-month period, they've really only dropped it down by half. So that kind of goes to show you how slow you may need to go in some of these patients. This gold column is the most common, and that's where in about 6 to 7 months, your goal is to be finished at that point. So every month you're making a drop from 90 3 times a day to 75, 60, 45, 30, 15. So it's 15 Q8, then you're doing 15 Q12, then 15 nightly. And in the extreme, instead of, so this kind of goes from month 1 through 7, then you can consider, just kind of for simplicity's sake, but a faster taper, you're making these changes instead of every month, you're making a change every week. And then at an extreme, you're making a change almost every day. But again, this needs to be individualized on the patient. I do think it's important to kind of talk about what data do we have in regards to this. So the consequences of changing the velocity of your taper. So over here, you have overdose, so the chance of someone being tapered and then having an overdose event. So that's overdose rate per 100 person years. So if you're decreasing the dose by about 10% or less, you're going to have a lower overdose rate. It's not 0, but it's lower. That can almost double if you start going 20 to 50% a month. And but it kind of hovers once you're 20 plus, then there is a significant risk. More notably, for a mental health crisis, which is a real issue, that really does go up the more fast you go. So relatively low at 10%. Once you get to 25, 50 or greater, I mean the rate triples, quadruples. So it really goes to show that the rate, I mean, we'll have some significant events. It's not just someone kind of getting upset. It's these are significant events. They're starting to get some data about how else can you supplement, what else can you treat for them. I think this is more interesting. There's not a lot of data on this, but mu agonists, or aka a lot of opioids, produce central hypogonadism in men. So there has been a systemic review that does show testosterone replacement can improve their pain, potentially by 2 points from 0 to 10. So that's not a little bit. It did improve with emotional functioning, which can be some of the worst complaints the patient will kind of submit to you. Though the insomnia, kind of social functioning really wasn't improved whatsoever. So again, this evidence isn't strong, but it's I guess promising. So there's going to be some patients that are just I would say a little bit more difficult. If they're challenging, you want to really, like was mentioned earlier, consider evaluating for opioid use disorder. So that's actually a DSM-5 criteria. So that would be 2 or more of these criteria. So taking a larger amount for use over longer periods of time than intended, persistent desire or unsuccessful efforts to cut down or gain control over use, a great deal of time spent procuring opioids, craving or a strong desire to use, recurrent use that creates problems at work, school, home, or interpersonal legal issues, putting themselves in hazardous scenarios, or the need for markedly increased amounts, or significant withdrawal symptoms. So obviously, if they have 6 or more of these, then it's likely a severe disorder. So what options do you have in that situation? So buprenorphine is something you could consider. Until relatively recently, if you wanted to use this at all, then you had to get specific training and a DEA waiver. Now that has been loosened to allow more physicians to gain access to the medications. Now you only need that more significant training if you're treating more than 30 patients with this medication. So that is a really good tool to consider, especially if that's a direction you want to go. So in summary, I kind of like this diagram because let's say you place the patient in a thought process that they really you don't feel like they need to be tapered. The end goal is to always kind of reconsider that in the future. So that might change over years as their life plans move forward as they get older. You may need to taper, especially as they get older or sicker. Tapering, may be the right or wrong issue. So you always want to have that you never want to just kind of give up on that thought process, because generally there's usually some reason that the patient could come off of them, or at least tapered. Over here, if you do think that the benefits of a taper outweigh the risks, then they may be agreeable, and which at that point, it's pretty simple. You're going to start thinking about speed and going down that route. But even if the patient is not, you may decide that because of their misuse or diversion or other concerns, you're still going to go down that direction. And you're really going to have to, establish that conversation, use your relationship with them, and maybe just plant the seed over a period of time. Maybe you're just pointing out your concerns, and you're going to bring it up next time. But I think this when it really comes into play is, again, you're going to be placed in situations where you may inherit patients that have been on these medications for months, years, decades. They may be placed on levels that you may not be comfortable with, and for a variety of reasons, you may have a threshold that you want to either taper someone down to, or maybe you don't want them to be on this medication at all. So I think establishing, what you're comfortable with, communicating that to the patient is important right off the bat. It's just like, establishing a relationship with your life partner. You want to kind of be upfront, I think, early. And so that, it's a lot harder to backtrack on some of these things if over time. And that being said, maybe you will still need to, but I think it's important for you to have a kind of a threshold. How much are you willing to prescribe? Because you're going to have to back that up. If you have enough patients, there's going to be a potential some complications. People are going to potentially get, due to polypharmacy or other reasons, people are going to have maybe bad outcomes. So you want to really be able to justify why you did something. You can show over a long period of time that you've been discussing tapering, evaluating them for other concerns, creating a plan, so that you can show that your head was in the right place, and that you're doing the best for the patient. Just real quick, so again, it is important to point out that unused opioids, especially if you have large amounts, you don't want them just lingering around the house. People can get robbed, broken into, children can reach them, animals. So they recommend that if the patient's going to throw them away, that they actually should be mixed in, with other materials like kitty litter, dirt, coffee grounds, so that they're not other animals or people don't get into them. If there's no other options, then you can consider flushing them down the toilet. Though I'm pretty sure I've heard some kind of funny stories of dolphins and different animals being exposed to these things and actually having addiction problems. So there's consequences of that too. And so they're really, obviously this is a multi-billion-dollar concern. Tens of millions of people are on these medications. There's a lot of room for more research, specifically in these topics. How quickly do you taper somebody, and how do you handle a difficult patient? So I think that's where we really need to focus on in the near future. Here's my references.
All right. Thanks, everybody. If there are any questions, we have about 5 or so minutes for the group to take them. I am reading the chat here. And so for those of you who need to have something answered at this point, please just indicate your question, your query.
So here's my slide on buprenorphine that answered the one question. Yeah, I would say that risk for, in general, is probably a safer medication. I don't know about, I think with hyperalgesia, the concern or the recommendation usually is to potentially come down on your morphine equivalents. So, and I do think this kind of falls in one of those categories that, you know, we're not completely sure, or there might not be an obvious, you know, best case scenario, best case, okay, if you have hyperalgesia, you know, you do X, Y, Z. I mean, very little in pain is that, you know, algorithmic. But trying a different class, you know, trying to come down the medication, I think is a reasonable approach. And with that in mind, you know, your tolerance and your adverse effects are going to come down. Again, I think shooting for a lower daily morphine equivalent is going to be, you know, the main theme when you're trying to optimize adverse effects from oral opioids.
All right. We have one more question here. Do you necessarily need to taper a patient who you inherit and is high risk due to concurrent use of benzodiazepines, Ambien, and about 80 milligrams morphine equivalents if they've shown to be stable?
I'm sure there's probably varying opinions on this, but I feel like one of the easier ways to at least like approach this is just if something does happen, you know, how are you going to justify what you've done? So I do think that it's, and one of my coworkers elsewhere, not here, inherited a patient just like this, was on, I think a higher morphine equivalent, was on benzodiazepines by the PCP, and he immediately, you know, talked to the patient, communicated to the patient that he was concerned about that. He went out of his way to, you know, begin communication with the PCP, that he was concerned about the combination, and, you know, kind of initiated the conversation if they could if the patient could come off the benzodiazepines. The PCP declined doing that, didn't think that the patient would tolerate it. There was a small event in regards to that patient not having a small, you know, I wouldn't say dangerous, but kind of a bad outcome. And there was a review by, I want to say, the medical board as to, you know, his approach. And because he, you know, documented that his concern, he documented the conversation, he documented the communication with the PCP. He, you know, it's a lot of effort, but, you know, it showed, you know, that what he, you know, his goal was and what he was doing. And they found that he was very reasonable, and, you know, nothing came of it. But and my colleague was very happy that he did that. So, you know, that's when this is going to come into play. You know, if someone's on benzos and Ambien and morphine, you know, it's not going to be an issue until it is. And you want to be prepared for that.
Yeah, I'm going to echo your sentiments exactly, and say that, you know, this, when you deal with patients who are on multimodal therapy, as this patient is in this case, just understand that that you deal with it on a case-by-case basis. But there are people who are watching, and there are probably more people watching. If there's a lot of this that's being done in a particular practice, I think there's more people that are looking other than a medical board, and I can attest to that. And so just be mindful that if you have one or two patients in your practice who's being treated like this, yes, there should be a concern within your local medical community about being able to justify why you're doing this. And if your actions are thoughtful and they're careful and they're patient-centric, and you can demonstrate that both verbally and on paper, then, you know, you'll remain in good standing. But if one has many patients who are like this, and there is lack of carefulness and thoughtfulness and justification on paper, that's when some practitioners will get into trouble by organizations other than just medical boards.
I would just add the Narcan prescription, especially when prescription of opioids with any benzos, that's a must. Patient should have an unexpired Narcan that the patient can use in case of an emergency.
Great. So everybody, thank you for, to the learners, thank you for joining us. To our educators, thank you for being here for everybody. It was really a great event this evening. And I thank you again. And we hope that everyone here will be with us during our next Hot Topics discussion and presentation. Good night, everybody.
Good night.
Night.